When you're doing neuropsychology, what you realize is, there used to be this distinction between, okay, there's it's brain and the parts of the brain, and then mind. And does the brain and the totality of the brain parts equal the mind? And I can honestly say, in my humble opinion, no. There's still something there that's more than the addition of all the parts. We're still learning so much about the brain.
Hello and welcome. We're so glad you're tuning into the Taking Good Care show. I'm Dr. Andrew Wong, based in Toronto, Canada.
And I'm Dr. David St. Arno, based in Edmonton, Canada. We're two practicing psychologists with over a decade of experience each, working in a variety of settings and supporting diverse populations.
Thanks for joining us. We hope you enjoyed today's episode. While we're both practicing psychologists, our podcast is intended purely for educational and entertainment purposes. It's not a substitute for professional mental health care or treatment. If you're in need of support, we strongly encourage you to reach out to a licensed mental health professional in your area. Good morning, everyone. Another Friday morning recording session. We've got Dave here. We've got myself. It's Halloween in North America, October 31st. Busy day for everybody who has kids. And, for anyone who follows baseball, North American baseball, Toronto Blue Jays are playing tonight. They're going for the World Series win, the World Championship. So everybody's really excited. Everybody's going to be really busy today. And with all that busyness, we were able to get a guest with us. Dr. Martin Logan is with us. You haven't heard him yet, but he's nodding. He's smiling, I think. And we're really excited to have him on. And Dr. Logan is an old supervisor of mine. When I was going through my residency / internship, being trained to be a psychologist, he was my first rotation, neuropsychology rotation. And it was such a joy. It taught me about work-life balance. It taught me about, how to be in this field professionally, being accountable to my work and having fun with the work, right? Sometimes, the work that we do is really serious, but we have to learn how to laugh too. And certainly there was a lot of laughing within that rotation, a lot of coffee breaks, going out for lunches. It was a lot of fun. So I will give an introduction and then we will hear from Dr. Martin Logan. So Dr. Logan is a neuropsychologist at Community Brain Injury Services at Providence Care in Kingston, Ontario, Canada. So that's about 3 hours east of Toronto. And he's been there for almost 20 years. Providence Care is Southeastern Ontario's leading provider of public and specialized care in aging, mental health, and rehabilitation. Dr. Logan graduated with his PhD in 1999 from the University of Calgary and completed a postdoctoral internship at Hamilton Health Sciences here in Ontario. He has worked in the area of disability and brain injury for over 30 years since his undergraduate days at the University of Ottawa. And he also has an enjoyment of North American football, which is shared by his son, both playing defensive end positions. And he wanted to make note that his son is way better than he is.
That's right.
And finally, Dr. Logan has been a clinical supervisor for 20 years, training future psychologists at the Kingston Residency Consortium. So welcome, Dr. Martin Logan.
Thank you very much, Andrew. I appreciate it. And good to be here. Good to be here. You probably couldn't see my grinning because it's beneath my gray beard, being as senior as I am.
Well, I wanted to add too that, this is such a delight to have you on because I know that you are a very humble individual. And at the same time, you have so much knowledge and you've been talking about potential retirement at some point. But this is one of those things that we talked about this a couple of episodes ago. It's just getting clinicians and psychologists on here who, you don't seek the spotlight, but you do such amazing work. And I know that because I've worked with you and just getting you on here to share what you know so it doesn't get lost in the future.
Oh, I appreciate it. I appreciate it. And that's actually being said without me even needing to provide you a final evaluation. That's excellent.
Yeah, there's no more evaluations.
That's all said and done. Yeah, good. No, I appreciate it. You are right. Am I humble? I don't know about that. I think it's more oriented towards I like to get across in terms of brain injury, how much I do enjoy the field, how much I enjoy working with the team that I have here and the clients that we work with. But it's one of those things where, yeah, I don't think our service is seeking out the limelight usually. And you provided this gracious opportunity, so thought we would take advantage of it and just kind of talk a little bit about what we do here.
And Dave doesn't know this, but Martin's a huge Dallas Cowboys fan. I don't know
Oh,
if
I
he
know.
still is, but having said that, I still wanted to invite him on anyway. Who likes the Cowboys? I don't know, but he does.
Is this going back to the 49ers? I don't know.
I do like my 49ers.
Yes, exactly. No, I've had to amend. That it's pretty rough watching them right now. I mean, they're not horrible, but they're Dallas. They break my heart every year. Hopefully the Blue Jays don't do the same. Well, we'll keep our fingers crossed. They're looking pretty good.
Yeah, I think I'm kind of the third wheel here. I'm totally enjoying you guys reconnecting, and I'm kind of going to sit back probably more than other episodes, but I think talking about sports, that's right up my alley. And then with head injuries and concussions and things like that, I think I can definitely chime in here and there. And so we're already there. I think I'm curious about even just the type of patients or clients that you see coming through the hospital
Mhm.
and the type of work that you do. I don't know a lot about it. So, and even for the listeners that might not have, ever experienced something like that, this is an area of practice that unless you've experienced it, you might not know very much about it. So,
Sure. In terms of our program, I mean, we are the community component of the brain injury services. So at Providence Care, there's an inpatient service as well as a community-based service. So a lot of our referrals come from the inpatient program. So Providence Care is primarily focused on rehabilitation. So they're not necessarily like an acute care setting. So a lot of people will go through Kingston General Hospital, which is the major trauma center here in town. And then a person gets transferred to the inpatient program. And then usually through physiatry and the team over there, they'll be, provided the opportunity to continue service through our agency. We, as an agency, we try to get people out into the community as early on in the process as we can. Andrew kind of knows why. We focus on something called participate to learn and roles as goals. So one of the things is to get the individual into the community, getting them back to the roles that they find to be meaningful and important to them. And when we do that, what we notice is that any kind of like rehabilitation process, whether it's using day planners for memory purposes or maybe goal management training for executive functioning or something towards that, if it is attached to a role that the person finds important, you're really not doing rehabilitation to the person. You're doing rehabilitation with the person because they're going to end up exactly where they want to be. You know what I mean? They're going to be doing whatever role is important. For a lot of people, that's maybe being, we were talking a little bit before the podcast about being a dad. That tends to be one of the really important ones for individuals. And so if I'm a dad and I've had an injury and, what I've noticed is memory and executive functioning are issues, and I keep missing appointments to get my son places, and I'm not spending that quality time. If I can attach those memory planners, day planners, use of a iPhone, those kind of things to making sure that I'm following through in that role, hey, it's great. So that's kind of our role. We get the individuals, they're back into the community, they're trying to find their way, they're trying to put things back together, and we're trying our best to work with them to do exactly that.
So I'm sure we're gonna deep dive more into those areas, Martin. And just to rewind a little bit, I'm just wondering how you became interested in this area of brain injury and rehab, because I think, like Dave was saying, like it's really interesting. Like unless maybe if you've had a brain injury, that will you then know what it's like to have to go through that experience, right? It's that lived experience, and then then becoming a clinician in this area as well, working with the diverse clients that you have and the different brain injuries, whether it's, an accident or a stroke and so on. There's just so many different variations of brain injury as well. So I'm just wondering how you became interested in it and sort of pursued this area of study.
Goes back a long way. A couple of things, I guess. One of the first things is the fact that when I go back and look at the research that I was doing in my doctoral studies, it was kind of influenced by a couple of events in my personal life. One of the things that I experienced early on, and when I say early on, I mean really early on, is I was about 3 months premature. So I had a personal experience of going through the system in regards to having what's more or less, I guess, similar to an acquired brain injury. When you're 3 months premature, there's bleed to the brain and those kind of things. So dealing with some of the aspects as a child, just kind of going through that, which, when I was growing up, you were gonna push hard and you're gonna get through this. So one of the things getting through it was I was trying to play sports and getting into the sports aspect of things. And I decided to play football, which was probably not the best idea in terms of, concerns about being premature and bleeds to the brain, those kind of things. So I thought, well, I'll continue. So throughout my high school career, I probably had, I'd say 5 or 6 concussions. The last one being just as I was kind of entering into the university level of sport. And number one, that last concussion, it ended my playing of football, but it did spark an interest, because when you're going through a concussion process, and we'll hopefully talk about this a little bit. It's a very complex process. It's not just straight up having like a hit to the head and therefore some bruising to the brain. It's more involved than that. And so again, just going through some of the counseling aspects, the treatment aspects of that, it really got me thinking, yeah, this is a pretty cool area, this neuropsychology bit. So that kind of fed the interest. And then I remember I was talking to my father about it, and he was, concerned. And he had some involvement in the past with a gentleman named Don Stuss, who is a neuropsychologist was a neuropsychologist, I apologize, at Baycrest Rotman. He says, well, why don't you give Don a call? Because I know you're interested in psychology, and maybe Don has some words of wisdom in terms of what area of psychology to pursue. And when I talked to Don says there's only one area, and that's neuropsychology. So I followed his lead and decided, let's give this neuropsychology a try. And that's kind of how I got to this point in terms of, this is the area of interest. When I was doing my research for my PhD, we were looking at more or less social cognition. So we were looking at how people experience success and failure, and looking at their attributions in terms of how they viewed that, as well as resiliency. And so we had a control group. We had a group of individuals who had what would be considered congenital disability or congenital diagnosis of cerebral palsy, which is very similar to brain injury. And then we had a group of individuals with mild to moderate traumatic brain injury. And what we noticed is that there's huge differences between people with the congenital based injury to the brain versus people who sustain these injuries as an adult. And again, that kind of colored or influenced my direction, especially in terms of treatment and assessment and everything that goes along with neuropsychology and rehabilitation psychology.
This is great. And I think I'll even back it up a little bit more. You touched on it in terms of there's only one type of psychology, and it's neuropsychology. For the listeners, if someone says, well, what do you mean? How come you're like, what's the difference between a psychologist and a neuropsychologist? How do you explain it to the general person out there in the elevator?
In the elevator? We're the zombies of psychologists. I mean, that's the thing, right? Brains. Everything is brain. And I don't want to just basically put it out there just like that, but it really is a big component. Is that usually when I'm working with a client, given the background in terms of the training and stuff, you really are thinking, okay, in terms of neural networks, in terms of how the person is processing the information, that's always kind of in your head as you're working with the client. I'm kind of a hybrid actually in this area a little bit, because I mean, my background was clinical. I was more focused on the clinical side. And then I got this opportunity because University of Calgary was just starting up a program in rehabilitation. And I decided, oh, that kind of looks a little interesting. So I went in that direction. And that was just after my conversation with Dr. Stuss. And, you know, so I had some of that clinical aspect, but then what you really notice is as you're doing the rehabilitation, as you're doing the neuro, it gets more focused on really the area of injury, or at least in the case of brain injury or disability. I don't like necessarily using the word disability, but that area. And then as well, just how, okay, if a person has gone through this situation, how does it impact them from a cognitive neuroplasticity kind of perspective? But I think to back it up even more, I do think there is a lot of overlap, of course, between clinical psychology, neuropsychology, rehabilitation psychology, health psychology. Like it's really hard to parcel out who, what's going on in terms of who does what.
Yeah. Yeah. So Martin, in so many years of experience, I mean, when people hear brain injury, I think the visual that people will get is like someone getting hit on the head,
Yep.
right? You bonk your head. That's pretty much what people will think of as brain injury. And perhaps, some hits are a bit harder than others. But from your experience, like if you were to convey, perhaps some misnomers or some things that people don't know much about when it comes to brain injury, what are some things that you think are critical for people to know beyond just a hit to the head? Like whether it is how difficult recovery can be, or this idea of the coup contra coup. See, I learned something from you, like coup contra coup injuries, where you hit the other side of your brain, even though you think you're hit on one side, it's actually the other side that gets hurt. Like what are some things that you think it's important for people to understand about brain injury besides just getting hit on the head?
Yeah. So, I mean, what I would say is when we're working with somebody outside of the roles as goals, participate to learn component, one of the things that we try to do early on is demystify the whole process, right? Like, I mean, we're trying to make it as palatable, as understandable as possible. And I think so. One of the first areas is how when an individual has experienced a traumatic brain injury, an acquired brain injury, because we do work with people with acquired brain injury as well, is how intellectual functioning is actually very rarely affected by the injury itself. Maybe processing speed has changed up, like how fast a person thinks about something, or maybe how the person articulates their thoughts, that can change. But the thinking itself, the intellect itself is actually usually very well preserved. So, and so for me, it's an interesting component because I get to meet these individuals usually after they've experienced an injury. But, the person that I meet is the person I meet. And so I'm never necessarily dealing with that previous person, that person, I'm using person a lot, but that individual remembers. I think that's a big part of it. So from a biopsychosocial standpoint, brain injury, exactly as you said, Andrew, isn't as simple as, I hit my brain and there's been a neural, break in terms of how the neurons connect. It's more, okay, that has happened. I've gone through the experience, but it's affected me in many more dimensions. So biologically, the injury occurred. Psychologically, the depression sets in, or anxiety sets in, or social stressors set in, where the family dynamic in itself changes. So it's a very multifaceted. So when I've been listening, and I mentioned this earlier, when I was listening to your podcasts, I think that anybody's going in and working with people with brain injury, or if you've experienced a brain injury yourself, I would definitely say, check out the grief episode, check out the trauma episode, check out the chronic pain episode, check out the anger episode, check out the mindfulness. All of these things are components of what a person goes through after having a brain injury, which means that they're just like you and me, other than, maybe, and I don't want to get into people's heads, other than going home tonight, maybe, falling down going up the steps because the leaves are there and it's wet. At least here in Ontario, it's sure wet. That's how close we are to the possibility of experiencing this ourselves. So, yeah, I don't know if that answers it specifically, but it's a much more multifaceted, complex thing than just hitting your head.
Oh, this is so interesting, and you can probably take it back further than me, but I know my own sports experience and the very little awareness there was. I mean, I remember playing U18 soccer, and our keeper had probably 3 concussions within a couple of weeks, right? And so, but not knowing really what to call them, and if he was good enough, if he felt good enough to play the next game, then he just did that. So I don't have a ton of experience in this area, but the little bit that I had in my graduate studies volunteering with Dr. Martin Mrazek, who helps out with the Edmonton Oilers and the Edmonton Eskimos, like some of the professional sports teams in Edmonton here, we were doing baseline testing, right?
Mm-hmm.
So
Mm-hmm.
actually getting a baseline of these players before a possible brain injury or a head injury, right?
Yeah.
And doing some of the follow-up testing for those that had a concussion or had some other head trauma. So you're saying you rarely know the people before, right?
Right.
And I think that is a hard part for a lot of people, right? They don't have that baseline testing of like, oh, well, these are my scores on these tests before I hit my head, and now I can tell that something did happen, and you don't have a scan. So how do you sort through that with people that are you haven't met them before, they're telling you things are different, but yeah.
As much as possible, when we're working with the client who sustained the injury, we're also working with the family and trying to provide as many supports as a network as possible. So a lot of the information that you're getting it firsthand from the client who's coming through the door, but you're also getting the concerns, the distress, the upset of the family members as well. So you're getting a picture, albeit somewhat of a skewed picture, unfortunately, because I think when people are in that situation of still kind of dealing with their own, for lack of a better term, traumatic response to the whole process, what you're hearing is kind of a viewpoint through the lens of a person who is having a really bad time of it. So again, we're going to try to get as many points of contact as possible, even outside of the family if we can, as long as the client is willing to allow us that. The other possibility as well, and one of the things that I do a lot of is neuropsychological assessment. So when we're doing these types of assessments, what we're trying to do is we're trying to get as much background information prior to the actual testing. And not to drop names, but Oliver Sacks. So Oliver Sacks, this is a story maybe Andrew has heard, but I'm not sure. I was at this event at Queen's, and Oliver Sacks was the keynote person. And for people who don't know, Oliver Sacks is a pretty renowned neurologist who has written a number of different books and just pretty phenomenal. So I went down, I saw his keynote, and then I ran down to the principal's residence, which is where this soiree was going. And I'm sitting there and I'm talking to this guy who was there early, and I'm looking at him, and he said, "What do you do?" I said, "I'm a neuropsychologist." He says, "Oh, do you know Luria?" And Luria, being a huge psychologist and a Russian neuropsychologist, especially during the World Wars. And I said, "Well, yeah, we learned about him in history of psychology class." Oh, he says, "Well, when I was pen pals with Luria," he said, "we had a lot of," and I'm looking at him and I go, "Okay, you're not Oliver Sacks by any chance?" He goes, "Yes." And I'm like, "Oh." So it got me reading about Luria. So going back to neuropsych, one of the things Luria said was, as much as possible, use the assessment itself, the assessment tool, just to examine the hypothesis that you've already developed based on the interviews that you've conducted. Mm-hmm. And that's a really good guidance, one of the best guidance that I ever received from Oliver Sacks, at least. And so that is what we do. We get as much background information. We go in, we do the neuropsych assessments. There's certain measures that we use to get an idea of where the person was functioning prior to the injury itself. But again, that doesn't really paint the full picture of who that individual was. So You're trying to garner as many resources as you possibly can to paint that picture of who the individual, who that person was.
Well, that's where I find, like you said, interviewing family members
Yeah.
and close friends and so on is so important because it gives you, they're the ones who experience who this person is now, right? So they're the ones who have these intact memories of, this was them before the brain injury, and these are all the changes that have happened now. I think what's really interesting, Martin, just from your reminder there, is that intelligence doesn't really change. But the number of times that I've heard where personality has changed, right? That's the interesting part is like, so the intelligence is intact, but the personality, the person who they once knew, to your example, who could take their child on time to appointments, that person's no longer there. Right. So the idea that I see you can explain a little bit more better than I can, but I think the idea that
Yeah.
everybody having to make changes, that the
Yeah.
brain injury doesn't just impact the individual who's experienced it. It impacts the entire environment, I think is really important.
It really does. And I was thinking about it before coming on today and thinking about some of the outcomes that the family experiences, that the individual experiences. And it's kind of interesting how it maps almost perfectly onto each other. Because I think if you ask a number of our clients, what's changed, what's gone on since the injury, and you ask their loved ones the exact same question, you're going to get things like changes in roles and responsibilities. What I used to do as a family member, that's changed. Different family members have taken on those roles. And as the person, from a rehabilitation component, as you're trying to help the individual, go get back into the roles that they once held, there can be resistance within the family too, right? Because all of a sudden that shift, and there's concerns, there's worries, because the second area of outcome that we see a lot of is the emotional, psychological distress that goes along with the actual injury, the guilt, the anger, the anxiety, fear, a lot of the things that you would associate with trauma, right? Because when we talk about traumatic brain injury, there's a trauma, not just a physiological trauma, but a psychological aspect to this. This is life altering for the person, for the family, and grief. And I think you guys talked about it the last time, which was it's a complex grief. You haven't lost somebody in terms of they passed away because of this injury. They're still there, but they're not quite the same. And that creates that complexness, the complex nature of it. Isolation, there's another one, right? Like a lot of people in terms of outcome of this, whether it's the family, whether it's the individual, it's the changing of friendships and people aren't coming around anymore, or I don't associate with those individuals anymore, especially if it's related to a lifestyle-based injury. And then what we do see across the board, and this is with individuals with brain injury and the families, is diminished self-care. They're not taking care of their health to the same degree, and that self-care diminishes a lot.
Yeah, I think grief that you're talking about, I see that so much that, again, not a primary area of focus, but I'm thinking to some of my clients who've had like motor vehicle accidents and have had concussions and just, sensitivity to light. So you can't go outside when the sun's shining, or, sensitivity to sound, or lack of energy. Like there's just so many things that all of a sudden their world closes down. And when I'm meeting with them, it's like, oh, there's another loss, right? There's another thing that you used to enjoy or you used to love that you can't do right now, right? And when I'm hearing you, it's like, if this is a drastic change, right? I'm someone who rode my bike to work and I'm someone who coached my kids soccer and I'm like, that's who I am. All of a sudden, I can't do all those things. It's like, who am I?
Yeah, it is. Who am I? And the thing is, it's interesting. We run a couple of groups, and one of the groups that we run is the post-concussion action group, and that's for people with a concussion. And we run a similar group for individuals with moderate to severe brain injury as well. And one of the terms, because a lot of people have a lot of emotional reaction to their situation, one of the terms that we use is acceptance. If you want to see a reaction to the word acceptance, people get so upset. What do you mean accept this? There is no way I'm going to accept this. So we have stopped using the word acceptance. We've started using the word acknowledge. Okay. So what we're doing is now we're just acknowledging where are we at, right? Take a look around. What's going on? What is your current situation? If we get too much in the headspace, I think we continue to fall backwards on this and we continue to decline in terms of our functionings. I think if we can acknowledge, okay, well, this has happened, this has occurred, this is my situation as it stands now, you're actually halting it at that point and saying, okay, this is what's happening. Now, based on what we're looking at in terms of the rehabilitation process and those things, now we're going to move forward. Now we're going to take everything into consideration, apply it, move forward, and see what we can do.
I'm glad I'm not the only one who has had that reaction to acceptance,
We
right?
all have.
Yeah, it's like, and I think even for you, the word rehabilitation, right? Like you're trying to regain functioning or abilities that you've lost. And so the focus is on regaining and working towards that. And if you mention acceptance, it's like, hold on, no. Like I'm trying to get back to where I was. So I don't want to accept this right now. So that kind of balance of like, okay, well, let's, like you said, just kind of acknowledge and recognize where things are at. Yes, you still want to get back to where you were, and there might be some things that we can do to help you with that. But accepting the loss, accepting the change, that is so hard. Yeah.
It's very hard. It's actually, I would say, almost more difficult for a lot of the clients who are coming in with mild, like concussion-based injuries, because they're so super acutely aware of the changes. And so it becomes a hypervigilance for the individual that, okay, so this has changed since the concussion. So if something else occurs and it's something that I don't want to happen, all of a sudden it's concussion. And you're like, whoa, hold on. It could be a myriad of other things, not that we're wanting to make the person upset in that sense, but we're just saying that sometimes a lot of things get attributed to the brain injury or attributed to the concussion, which are just life. And so, you guys were talking about mindfulness in the podcast. That is a huge focus for us, actually, as part of whether we're working with an individual with concussion or with an individual with moderate to severe brain injury, is trying to work that in, because you get so caught up in your own thought and your own thinking and your own worries, concerns, the fact that I've changed, this is how I've changed, I can't, okay, let's take a step back. So we're always working that in to any of the rehabilitation that we're focusing on with any of our clients.
So as we're moving towards this idea of acknowledgement and rehabilitation, a couple of words often come up, and one of them is the idea of neuroplasticity. Right? It's this fancy term, but I think it's an important one where, you hear about it all the time when people talk about traumatic brain injury and, can the brain learn? And people say, yeah, the brain is plastic. Well, I think to many people, it's like, what does that even mean? What do you mean my brain's plastic? So talk a little bit more about this idea of neuroplasticity and how it applies to rehabilitation after a brain injury.
Neuroplasticity, yeah, big word. So if somebody's coming in, how we describe neuroplasticity is this: our brains are always changing. Our brains are always modifying. Everything that we do each day, our brains learn new information. That in itself is neuroplasticity. So it's any new connections that the brain forms between neurons. I know that the old adage is, and I think it was said actually in one of your other podcasts, neurons that fire together, wire together. And that's neuroplasticity. It's a bit overused, but it actually works quite nicely. For most, we're trying to say, yeah, okay, look, when you're doing the rehabilitation, when you're using new techniques, we're focused on the neuroplasticity. We're focused on the brain changing to adapt to what's been going on, so that in a lot of cases, we're forming new connections, new routes for information to be processed. They may not be as strong or as what you remember in terms of how you were thinking before. However, as you get used to the process of either maybe a memory technique or a new way of thinking through a puzzle situation, like in terms of executive functioning, whatever that looks like, it'll start becoming more and more routinized and more a part of who you are. A lot of the difficulty around neuroplasticity is that will it be the same as it was before? And the answer is no, it won't. It could be better. It may be better, but it won't be the same. So what you're as well trying to do is you're trying to foster this idea or this thought process within the individual going through this is that, okay, I can't guarantee that what you're going to experience in the future is the exact same thing that you experienced in the past. But what I can do is I can make it move from here now. And that's what we're going to do is we're going to use neuroplasticity to go forward and take advantage of it. The neuroplasticity component, for a lot of people, they think it's going to be this perfect solution so that by the time I'm done rehabilitation, I'll be the exact same person I was before. We are always very clear, you won't be. You won't be that same person. But that's just because of time, right? You know, we talk about that a lot is I'd love to be the same person I was when I started this program 20 years ago, but time has taken its toll, I guess. And so I am changing as I move forward. And we always are saying, like, look, if you want to be the same person you were today, tomorrow, fine, but you won't be. So let's take advantage of it. Use as much as the plasticity. If it's a new technique of thinking about things, if it's a new technique of remembering things, if it's a new technique in terms of even getting out and getting exercise because you can't ride your bike anymore, so we're going to use the pool instead, we're making progress.
This neuroplasticity, or when people say the brain is plastic, is one of my pet peeves because when I think of plastic, I think of Tupperware and I think of something that goes in the landfill or the ocean and does not change. It's really durable and hard to change, hard to break down. And so I'm like, it's actually the opposite of that, right? Like saying the brain is plastic means the brain can change and it's malleable. So for the listeners, don't think of Tupperware, think of something else, the opposite of that. That
like Play-Doh.
Yeah.
Or even a plant. You know, like growth. I mean, that's the thing is you can take a plant and like a bonsai tree, right? You can trim, clip, work on that tree to form something. It's a piece of art, and really that is what it is. I think that people don't realize how much control they do have over their brain. And I think that's part of that demystifying process is just saying, look, you actually have more control over your brain than you think you do. And actually, if we, and this is a big part, if we draw our attention and focus on this specific area or whatever you want to focus on, and we put a lot of effort into this, there's a lot that can be done, and there's, you know, whether there's limitations on that, I'm not 100% sure, but I don't know. You know, you think about a person learning a guitar, you think about a person learning how to you know, ride a bike, and that's usually the example we use. You know, when you're first starting, you're literally falling off the bike. You don't know how to get your feet in the pedals, and you're continuously thinking about it. And then all of a sudden, one day, it becomes just routine. Yeah. And then you're doing it. And where that transfer occurs, and we talk about that a lot in the rehabilitation, is at some point in time, you're just going to find that you're going to be doing certain things that you never thought you'd be doing again, or that you thought, okay, this is a barrier. All of a sudden, you're doing it again. And you won't be able to tell me when that occurred because it just happens. It just does.
You know what I remember though, Martin, being in your rotation for brain injuries is how much support people needed to get there. So as we're talking about the individual, like putting in the effort and, you know, really trying to learn something new or something different, it was, if my recollection serves me correctly, it was never just the one person doing it. I remember there being behavior support staff. If they were living in the community, there would be people visiting to make sure that they're on track. There were family members, and even some family members had challenging times in supporting that individual. And so it really seemed to take a whole village. It wasn't just, pushing that person to do it. It was like, how do we support this person
Mhm.
and how to get to their purpose or their goal?
And good point. If it did sound like I was saying pushing the person, I didn't mean that, because you are walking with them. Okay, so yeah, we have an amazing staff. So in our program, we have rehabilitation counselors. So they're individuals who work with the client on a weekly basis, usually, and help the client develop a service plan based on the roles and the plans that the person wants to get done. And yeah, no, there's a lot of support there. And I can't say enough about the families, the friends, the networks that the individual has in the community, because when our staff go in, they're not just working with the client, they're working with the family. So the family is always, as long as the client's willing, and that's a big part. But everybody's learning together, everybody's moving together in the same, hopefully the same direction. Sometimes you get parts moving in different directions, but you try to figure that one out. And we end. So our day is 9 to 5. So after that, if the person has a strong network, especially a strong family network, it's really amazing at what can be accomplished. The thing is how, and in those cases, what we try to do is then we try to support the family as well to make sure that they're feeling that they're being taken care of. I think one of the hardest conversations that we usually have with family members is talking about the fact that the family members need to take care of themselves. Every time we have that conversation, the family members are looking at us like, "What are you, crazy?" But usually after a year or so, you watch the family and they're like, "We get it. We get it now." In order for me to be of the utmost benefit to my loved one, I as well first have to take care of myself and do that to be a strength in these situations. So I appreciate it, Andrew. Yeah, no, I mean, there is the component of the working hard and of the client, but also in terms of the support network that the individual has, it makes a huge difference.
That effort, that working hard piece, I remember a graph that, it's only been in the recent, I don't know, 10, 15 years where recognizing that the brain is changing throughout the lifespan, right? But what changes is that as you get older, it takes more effort to make changes, right? So babies that are sleeping for like 12 hours a day because their brain is rewiring itself every single day. And if you possibly have an injury when you're 5 years old versus 50 years old, there's going to be a difference. But so sometimes people say like, well, can this change? And it's like, yes, that's the good news. And the bad news is it's going to take you more work than if you were 15 years younger or if you were 30 years younger, right? Like it still changes. And that whole like can't teach an old dog new tricks, right? That's been kind of in our mindset for a long time. But that is not true. We can teach old dogs new tricks with a lot more effort and support, like Andrew's saying.
I sure hope so. Uh,
Martin, I think it was you who told me. I think it was on a rotation when you said, Andrew, and this is part of your dark humor, I know. If you're ever going to have a brain injury, have it when you're young. It's easier to learn or to have that sort of that neuroplasticity piece. It's like it's easier to learn something again when you're younger.
Well, I should actually refer to you guys because I mean, the clinical psychologists here in terms of stages of development, right? But there are stages of development. There's also stages of neuroplasticity, and David, you're bang on. Like there are certain ages where we see that like spectacular growth in regards to neural connections, how different areas. I mean, you think about a 1-year-old in their vocabulary as it takes off, and you're just like, holy crumb cakes, this is amazing. Who even said these words to this kid? Then we go through a stage, usually later in life, in our teens and stuff, where there's pruning occurs and some regrowth. And then as well, when we get into our early adulthood, these things called our frontal lobes start to come online a little bit better. And literally, I got a 22-year-old, so I can honestly say, yes, at this stage, that finally these executive functions, I'm joking. Well, I'm kind of joking, come online. So are there stages where neuroplasticity is easier? I believe so. I believe so. But you're also talking to somebody, speaking about old dogs and new tricks, but who, when I started, you roughly had a 12 to 24 month window. That's what you were giving the person after the person had a brain injury. And now we know, okay, maybe that a lot of that neuroplasticity is going to occur within that framework, but it's ongoing. And we know that for sure now, right? Like with the advent of functional MRI, SPECT, those kind of things, we actually have documentation that this is occurring and continuing to occur. So yeah, continue to work on neuroplasticity because it's hugely important. And Andrew said something about neuroplasticity. We'll talk about this, and everything that you guys have done so far in terms of your podcast, that's really neuroplasticity, right? Like, I mean, anything that you're doing in terms of a mindfulness work, or you're doing in terms of adjusting to the loss of a significant other, or in terms of that, is all neuroplasticity. It's making these new connections, making these adjustments, allowing our brain to accommodate. And I mean, if we wanted to get into, I know you guys are going to do an ACT therapy session, but make room for what's going on now. Like making room and accepting or acknowledging your situation, that's incredible neuroplasticity. And when we're sitting down with our groups, the therapeutic intervention in itself is creating a very fertile ground for some major neurological changes, cognitive changes. Yeah.
Wow. Thank you for continuing to plug our podcast, man. Like,
hey, I'm trying my best. It's a great podcast.
The check's in the mail.
The check's in the mail. That's right. Martin, you talked about roles and participate to learn. You and your team have a great paper. I know it's a little older now, but you guys had a great paper and the research you did about roles as goals and participate to learn. I think that is such a great way of going through rehabilitation. Right. And you know what? I use that same model when I was with the school board with kids who are having challenges. It's giving them a purpose, giving them a role that they can work towards, not just telling them what to do and instructing them on what to do, but it's putting it into action. So I'm wondering if you can chat a little bit more about this idea of roles as goals in terms of rehab and brain injury and what that's all about and why you think it's so important for someone going through brain rehab to have a role.
Really, roles as goals, participate to learn. That was my predecessor, Dr. Peter Carlson, was asked by the Ontario Neurotrauma Foundation. So in Ontario, David, there used to be a foundation that was directly related to neurological functioning, any kind of disorders in that area. Unfortunately, there's been some changes in the funding within Ontario, and they no longer exist. But when they funded this study, the big focus was on, okay, are we doing a disservice, or are we doing something that where when we're teaching a person how to do a task in a laboratory-esque kind of setting or a hospital setting, and then asking the person then to go out into the community and do it, how does that generalization work? Or is there a better way that we can work with a client in order to minimize generalization, but still allow the person to get back into what it is that they want to do? And when we really looked at the literature and examined it, there was Ilvisacker was a theorist, Hanks and Johnson Green. They were talking about traditional versus contextual rehabilitation. And that's really where participate to learn and roles as goals came out of. The nice thing about it is that you move the person who's had the acquired brain injury into the actual role, and it takes place on site or in the context. It doesn't require generalization. The focus is actually more on almost modifying the environment than the actual person themselves, which is, I think, a really big modification. And then participating as soon as possible. So usually if people are in a rehabilitation setting and they're getting, their rehab in a gymnasium or something like that, a lot of times they're doing it, but they don't see the point. It's like, yeah, I get why I'm doing this, but at the same time, how's it going to apply to me being a dad? I don't understand this. So again, it's bringing out another level. The other aspect of getting back into roles, I think, that are important for the person is, again, going back to neuroplasticity. That's a huge part, right, of neuroplasticity is having a role, having a meaning, having a sense of self, being surrounded by stimulating environments and the people that you love, and kind of being a new explorer. One of the things about Participate to Learn as well is that when I was starting, it was errorless model approach. So you weren't going to allow a client to actually make a mistake. You were going to support the client through and through so that gradually you'd increase the difficulty of the situation, but the client would never really make an error. Now, through Participate to Learn, not only as our team, we're open to errors, we're open to the client, without much risk, but at the same time, having mistakes, making mistakes, then taking and examining those mistakes or how it didn't work out, and then trying to bring it back into the person's rehabilitation and then making it applicable. So I agree with you, Andrew. I think roles as goals, the idea of identifying those things, I mean, it kind of reflects a bit of a CBT model approach in terms of therapy, but I think for most of us, it's generally kind of what we're doing. We're just not doing it explicitly. We're doing it implicitly.
So for an outsider who hasn't read the paper,
sure, sorry about
that.
Yeah,
no. I want to clarify this because I like the sound of it, roles and goals. Yeah. So I'm assuming the goals are directly tied to the roles that someone wants to be doing. Is that fair?
The role is the goal.
The role is the goal. Okay. Yeah.
So if my role, going back to the being a father, if my role is being a dad and being a dad who's there for my child, that's the goal in itself as well. So when we develop a service plan with somebody who's gone through an injury, the goal is at the top. The role and goal are at the top. So being a dad. Then what we do is we talk to the person of, okay, what has worked for you in this role? What hasn't worked for you in this role? What are the barriers, in terms of you going back to this role? And then those are the plans. So when we develop the plans of how we're going to actually achieve that role, we're going to look at, okay, what's causing the issues for the individual in terms of doing it? And can we employ a rehabilitation technique that will help the person either overcome it or modify whatever the barrier is? So one of the hard things, and I'll talk about some of the negatives because there is some negative to this. We don't think of ourselves in roles. So when we sit down with the client, when we sit down with the family, and we say, okay, what roles do you want to get back to? A lot of times they'll look at us and like, what? What do you mean roles? Like, what are these roles? So what we've done is we've actually developed a questionnaire. And this is since Andrew's time. So we developed a questionnaire since Andrew was here, because Andrew was always talking about formalizing this and making it into a new therapeutic technique. So really, actually, we borrowed from acceptance and commitment therapy. And when we sit down with the client for the very first time to talk about what roles do you want to go back to, we're looking in really 4 domains. So we talk about work and education, we talk about leisure, we talk about personal growth, and we talk about relationships. And we get the person to say, on a bullseye, where would you place yourself in terms of are you doing in any of those areas? Is there an area where you're finding that you're not where you want to be? And that you would say, yeah, it's because of the injury itself, and I'm not performing where I would like to be on this chart. And then from that point forward, we have a number of different questions that we ask the client based on whatever area that they're talking about, well, let's say relationships. And we say, okay, what have you tried before? What has worked well for you before? Have you tried this? And so we get a little bit of a more deeper level. And then what we usually do find is that something will pop in those conversations, because you really are building relationship with the client through these discussions. You all of a sudden end up with this role. And we've had roles from domestic goddess to being able to do my own SHI, whatever. So we try to use as much as possible, the exact words of the client to even make it more meaningful.
I think what's really cool there, Martin, is again, it's not just instructing the person, this is what you have to do, steps 1 to 5, and then you'll get there. It's creating a relationship, right? So even as we talk about neuropsychology, I think again, within the field of psychology, I think when we hear neuropsychology, we think about assessments. Everything is much more formal, maybe a bit more specialized. But here we are talking about creating a relationship, almost this counseling relationship still, right? Like trying to form some kind of connection, some kind of rapport to really understand the person who's sitting across from us and what they want in their lives moving forward.
Yeah, exactly. Why wouldn't we ask the person who's experiencing the situation for their opinion? And I do think, when we started this discussion, one of the questions was, what's the difference between clinical and neuro and rehab and health and forensics? I mean, there are differences, but I think it's more the similarities that are the important part. And I think that in terms of looking at the individual as an individual and going to the source for the information and trying to have that person take on the empowerment as much as possible through the process, they're core. It doesn't matter what area of psychology you're practicing.
Seeing the whole person, right? And sometimes when I think about neuropsychology, I'm curious. I want to throw this at you because since you're here, I get to ask you. You talked about imaging a bit and how much that has advanced the field. And I'm curious in terms of like, how often do you have like an fMRI image and a specific area of the brain that's been affected by a stroke or by a head injury, and then you're looking at how it has impaired or affected certain areas of functioning? And how often do you go like in the reverse, where you're doing an assessment and you're measuring, say, like memory, and then you're going, okay, here's some impairments. We think it's affecting this part of the brain. Yeah, I'm just curious about that.
I think, and I'm sure my neuropsychology colleagues will correct me if I'm wrong. It kind of used to be that way, right? So neuropsychologists would be coming in. There was no such thing as functional MRI at the time. And so you're doing this, intensive, and that's where Luria, for instance, got his start, right? Was actually working with soldiers who came back from the war and saying, okay, so this area, this is what's going on for the person. These are their areas of deficit. So in all probability, it's more of a right hemispheric injury, and maybe it's more of a parietal zone that's been affected because obviously, there's some changes in terms of tactile components and those kind of things. And then, later on you'd say, yeah, okay, that was the area that was hurt. I think, as you were saying, we're much more in the other direction now. So the fMRI, the PET scan, the whatever scan that you're doing is going to be saying, okay, yeah, this is the area of the brain that's affected. So the idea of doing a neuropsych to pinpoint, Brodmann's area or number, whatever, I think is passed. I think though, when my temporal lobe is impacted by an injury, or yours or Andrew's, it's going to be different. The outcome is going to be different because all three of us have different brains. So then how does that affect and impact the individual? Okay, let's do the neuropsych assessment and get to the bottom of it. Because for you, it may be, a situation where, it's an encoding issue for memory or something like that. But for Andrew and I, it's an attention and concentration issue, not an encoding issue. So how you would actually go about supporting the person in terms of the rehab model is actually quite different depending on where memory is impacted. So I think that's more the focus. And when I was at the University of Calgary, and then when I was in Hamilton, really that's what we were doing is you're doing a neuropsych assessment, but the recommendations themselves were going to be, okay, how do we make the best outcome for the individual, because it's that individual's brain.
Amazing.
But it is amazing. Like, I mean, the functional MRI stuff that's coming out now, especially as it relates to therapeutic intervention. Like, I know that you guys were talking about this in terms of, I think in the psilocybin podcast, but as well, the mindfulness one. Like it is like default mode network, this whole new focus that's out there right now in terms of podcasts and everything. And maybe we'll do another one on that one later, but is we're getting at these networks now that are amazing, because now we're saying, yeah, there actually is an area where there's probably this whole sense of identity and the whole sense of self resides here. Whoa.
Well, there's still so much we don't know about the brain, right? Like this is
Yeah.
this is the fascinating thing, and this is why I think I went into this field, is because there's just this organ in our bodies that, looks so alien-like, but yet it controls every facet of our lives. Even like you're saying, like even with our identity, like they're starting to come up things like, this is the part of the brain that, perhaps helps with identifying who you are, right? Like
perhaps, the humbling thing about neuropsychology, and I'm trying to remember what I was doing. I think, unfortunately, I was listening to a different podcast. But anyway, I think the interesting thing is when you're doing neuropsychology, what you realize is, there used to be this distinction between, okay, it's brain and the parts of the brain, and then mind. And does the brain and the totality of the brain parts equal the mind? And I can honestly say, in my humble opinion, no. Like, there's still something there that's more than the addition of all the parts. It's fascinating. So yeah, to your point, Andrew, I think, we're still learning so much about the brain, and we think we've got this ability to map it, we've got this ability to image it, we got this, and we're still learning.
we're drifting into the area of philosophy now.
We need another podcast, and this one is going to be a long one.
Hey, give me into, can the mind change the neuroplasticity of the brain? That's a whole new podcast.
Wow. Yeah,
mind blown right here.
Well, yeah, I've been listening and thinking, like, yes, experience, therapy, nutrition, exercise, like all of these things can rewire the brain. And now you're adding this other layer to it, like the mind itself thinking.
Changing.
Yeah.
And,
Wow.
and we've seen that, right? With studies where people have thought about playing the piano. Guess what? It changes the connections of the brain. You don't even have to play piano. So it's cool stuff.
You're not going to retire anytime soon. You're going to keep doing this. And
going back though, I wanted to say about the one podcast you guys did, and it struck me because we have a new program here at Providence Care Hospital, which is looking at psychedelic components in terms of treatment. And one of the interesting parts, when you're working with people with brain injury, especially around concussion, is this fierce sense of loss, self, who am I now, these kind of things. I think, in the future, I was listening, Zindel Siegel. So these are the two individuals from University of Toronto. So one is Siegel, one is Farb. They just came out with this book, and it's a very cool book where it's looking at, okay, in terms of plasticity, in terms of this default mode network that we briefly are talking about, and I'll get off it here in a second, is how do we go about changing it? And they were talking about mindfulness because Siegel's, that's his area. But they're now talking about its sensory foraging. which is kind of a step back from mindfulness in terms of meditation, to just get a person's toe in the door of trying to modify how they view themselves and how they interact with the world. And I think, we've got some area to grow in regards to especially sensory input of information. And I think that in the future, I mean, we're just starting this process in terms of psychedelic use in individuals who don't have any kind of injury to their brain. But I do see a future, possibly, where we're going to start looking at new sensory inputs to start to unravel this idea of a sense of identity self. But that's for a future episode.
And you're going to lead the charge in Ontario. You're going
Yeah. No, thank you.
Oh man, like with everything that we've talked about today, it's so hard to even conclude or come to a bit of a reflection of what to take away because there's so much. So I'm not going to be the first to go. I'm going to throw it out to you, Dave.
Of course. I see what you're doing. Yeah, yeah, there's a whole bunch of really kind of interesting and mind-provoking things that were talked about today. So, but I'm going to keep it simple. I'm going to go back to the neuroplasticity. And for a lot of people, this is going to be a pretty new term or a new concept, right? And so understanding that our brain is always changing. And I think what I'm taking away from Dr. Logan today is that like making those changes meaningful, right? Connecting them to meaningful aspects of your life is going to help with doing the effort and the work, especially coming back from or recovering or rehabilitating from a brain injury, from a major loss of function and identity and all of those things. It's really hard. And so if we can connect it to meaningful parts of your life and your values and what's important to you, that'll make things a little bit easier on this hard journey. So yeah, thank you for that.
I think for me, there's so many things as reminders. I haven't practiced in the area of brain injury for a little while now, but there's so many tidbits, even just in terms of the idea that look, anyone listening, even if you're a caregiver, you're not the one who's experienced a brain injury. You're certainly not alone. I know that oftentimes it feels like a very lonely process and a very frustrating one at that, but you're certainly not alone. There are supports out there. And to Dave's point about neuroplasticity, it's not even just the person who's gone through the brain injury that's going to experience neuroplasticity. As the caregiver, as the person who is on this journey with the person with the brain injury, your brain is neuroplastic as well. You're learning and we're adjusting and adapting as we go along this journey. So there's going to be grief, there's going to be anxiety, there will be possibly bouts of a depressed mood or a low mood, so many things that we're going to experience, but it's a journey and, we're going to learn from it.
Yeah, I think the idea of reconnecting with the idea that if you make a mistake, you learn from it and you move forward. And to borrow a statement from somebody of my generation when I was being trained, Viktor Frankl, a person who has a reason why can deal with any how. And I think that's a really important thing. And that's, when you're going through a situation of having an injury, there's people there to support you. There's people there who can help. But again, if you have a clear idea of where you want to go, it makes a world of difference.
I want to say one more thing that just, this injury, it's an invisible injury for so many people, right? So physically they might appear the same. And I think talking like Andrew's saying about loneliness, oh my gosh, this injury that is hard to measure, that is hard to understand, that other people are not going to see, can make this a lot harder for living and functioning and recovering. So
Yeah. So, Dr. Logan, thank you so much for being on our episode. There's so much more that we could talk about, really. Even as we talk about this, like there's certain clients that come to mind, it's just the journey that they've been on. So, thank you for sharing your wealth of knowledge. Hopefully, we'll have you on again at some point.
Yeah, that'd be great.
I hope this was fun for you too. I know it's your first podcast episode, so I know you've got so much more to share.
Given my rambling responses, maybe I should be on the ADHD one next time.
Wait for the request for other podcasts to be coming in soon. So, keep some space for us in the future.
For sure.
Thank you again, and take care, everyone.
Take care.